it's not very easy, it's also not very clear, we'll get to that. All these slides will be on Blackboard, so there's no use in trying to copy the slides, just perhaps make some notes on the comments and the thinking behind the slides. So, let's start. And I'll try to finish at about, in 50 minutes or so you have a 10-minute break for the next lecture. Can somebody give me a quick definition? What is the definition of the metabolic syndrome? What is it? Is there a definition? There are no wrong answers here. I just want to have some feeling of your background knowledge. Who will give me a definition?
You have at least 5 of the hallmarks.
5 hallmarks?
Yeah.
What are they?
Obesity.
Inflammation. High blood pressure.
Insulin resistance.
Insulin resistance.
Lipid profile. Some changes in the lipid profile.
Something abnormalities in the lipid profile. Is diabetes part of it? It is? Is it or is it not? Insulin resistance, not diabetes. Impaired glucose metabolism, pre-diabetes. Glucose levels that are higher than normal but not diabetes, is that part of it? That is part of it. So then we have 6. Do you need to have all 6 or all 5? Thanks. What do you think? Do you need to have, you said you need all 5.
No, you just need a few.
You need a few. Okay. How many? Any idea? Okay. Well, all this is very useful because it's very near the issues that are at play. Let's say, are any of these, you need a couple. Are any of those couple obligatory? Must you have at least these and then others? Or is it just, let's say, 3 out of 5? Any 3 out of 5? Does anybody know?
Depends on the source that you look into.
Source?
Yes, there's many different definitions.
Very good. There are different definitions. And some have obligatory criteria, some do not. Yeah. Okay. Lack of physical activity. Is that part of the syndrome?
It's a small cause.
The cause of the syndrome. Or that part of the syndrome. Okay. Well, let's see what the literature has about this. Yes, there are different definitions. This is the most widely used definition. It's also an international definition, because yes, there are European definitions, there are several American definitions, about 3 I think. These definitions have also changed in the past 20 years, but this is the IDF definition, and it is an international definition, and this basically is the definition that is most often used in this country. First, not obesity, but in fact central obesity. And in this definition, that's an obligatory criterion. You must have this. It's funny, because if you look at the other criteria, and if you ask yourself the question, do non-obese, non-centrally obese people exist that have even all 4 of those? Yes, they do exist. Yet, by this definition, they do not have the metabolic syndrome because they do not have this. Like any syndrome or disease, criteria are a matter of opinion and a matter of agreement. If you have made an international agreement about it, then this is what you use. That is true for diseases as well. If you look at a disease such as systemic lupus erythematosus, that has a long list of criteria, But clearly some people who do not fulfill the criteria actually do have the disease. So these so-called diagnostic criteria are never 100% sensitive. That's not specific to the metabolic syndrome. You will find that in any part of medicine where criteria are used to define a disease or a syndrome. So nothing special here. Waist circumference and 2 out of 4. High blood pressure, it's this, or treatment. Triglycerides, so here's the dyslipidemia, high triglycerides or treatment. Low HDL cholesterol specified by gender or treatment, and a fasting glucose above this. So a diabetic person can actually have the metabolic syndrome. Diabetes is not an exclusion criteria. So a person with the metabolic syndrome can have normal glucose levels if he has the other criteria. He can have impaired glucose metabolism if it's between 5.6 and, what's the fasting criterion for diabetes? 7.1 actually. So if it's between 5.6 and 7.1, or if it's above 7.1, it's actually somebody with type 2 diabetes, but with the syndrome. That's possible. So this is the definition. Insulin resistance is not part of the definition, as you can see here. There are sets of criteria where it is part of the definition, not in this set. Physical activity is not part of the criteria. So, what do you think, what is the cause of the metabolic syndrome? Does it have a cause? Does it have a single sort of underlying problem, which is the cause of this so-called clustering? Now, the clustering simply means that these phenomena occur more often together than you would expect by chance alone. No person with high blood pressure can have tuberculosis, but that's not a syndrome, because high blood pressure and tuberculosis have nothing to do with each other. Here we have a syndrome because these things are thought to have something to do with each other. They occur more often than predicted by chance alone. That's why it's a syndrome. So what's the underlying problem with this syndrome? You said it's physical activity.
It's lifestyle.
Lifestyle. Other? What is lifestyle except from physical activity?
Nutrition.
Nutrition. Any other?
Genetics.
Genetics. Genetics of what?
Metabolizing proteins or transporters for nutrients, etc.
Many bits, or one genetic thing that leads to all these things?
Many different things. That
And
would
it's
lead
not
to
one.
parts of-
It's not one thing then.
No.
It's several things. And with the lifestyle, is it one thing or is it several things? Is it one thing about lifestyle that predisposes you to all these things? Or not?
It's probably a combination of exercise.
Probably a combination. So we have lifestyle, we have genetics, do we have other things? What about insulin resistance? Is that a cause of the syndrome? Okay, we'll get back to that later. The other question perhaps is why bother? It's very prevalent. Any idea what the prevalence of this syndrome is in the Netherlands? Among adult people? 20 to 90? Any idea? Is it 1%? Is it 10%? Is it 50%? 90%? It's actually about 20 to 25%. Compared to other Western countries, is that higher or lower? In the UK, is it higher in the UK or lower?
Higher.
It's actually higher. Why is that? Because the Dutch cycle more, that's the answer. They have a higher general level of physical activity, and that's mostly explained by cycling. Not by walking and other things. So here are some prevalences. This is 2005. Prevalences are increasing. You can see that prevalences are quite high. Also, they vary considerably between men and women and among countries, but they are high. So it is a it is an interesting problem. Why actually is it an interesting problem in the sense that what is the ultimate prognostic problem? You have the syndrome, so what? Do you die of the syndrome? You die of the consequences of the syndrome. You die of cardiovascular disease. And perhaps of, what's the other thing that the metabolic syndrome predisposes to? It predisposes to cardiovascular disease, myocardial infarction, stroke, peripheral arterial disease. What else does it predispose to?
Diabetes.
Diabetes. And of course diabetes itself predisposes to cardiovascular disease, but diabetes predisposes also to something else. Not so much cardiovascular disease, at least not large artery disease, it does that too, but also, and very strongly, microangiopathy, which is, in diabetes, what is the classic 3 microangiopathic complications of diabetes? Is retinopathy with blindness at the end, nephropathy with renal replacement therapy, dialysis, transplantation at the end, and neuropathy with many manifestations. Can be painful neuropathy, can be lack of sensory qualities that predispose you to ulcers and so on and so forth. And that in itself carries, although most people actually do not die of microangiopathy, except in renal replacement therapy, but it does represent an important burden of disease. Which of the associations is stronger? The association of metabolic syndrome with diabetes or metabolic syndrome and cardiovascular disease? What are the relative risks of diabetes given the metabolic syndrome compared to not metabolic syndrome, and the relative risk of getting cardiovascular disease given the metabolic syndrome versus no metabolic syndrome? Which is the strongest association of the two? No, it's actually diabetes. The relative risk of diabetes given the metabolic syndrome is maybe about 6 or 7-fold, and for the cardiovascular disease it's about 3-fold. But the basic rate of cardiovascular disease is already high. So your chance of dying of cardiovascular disease without, if you do not have the metabolic syndrome, still your lifelong risk still is about 40%. But in the metabolic syndrome / diabetes, it's about 80%. Your lifelong risk of becoming a diabetic may be something like, without the metabolic syndrome, maybe something like 2%. And with the metabolic syndrome, it may be something like 20%. So the relative risk is much higher, but your absolute risk is actually lower. That's a paradox. But it's actually understandable from the pathophysiology of diabetes, because these factors that are part of the syndrome have something to do with becoming a diabetic, as we shall see. Another question is, why do we use waist, or why do people in that list of criteria use waist rather than BMI? And here is the answer. BMIs can be equal, but nevertheless fat distribution then can be quite different. Here the classic apple form and the pear form, the male and generally female form, and it is generally thought that the fat here, whether subcutaneous or visceral, is the source of some metabolic problem much more than the fat which is here. And that's why at least many people prefer the central obesity criterion to the general BMI criterion, because that general criterion hides this difference. It also has another problem, which is that young, very muscular people, not fat at all, can have a high BMI, but they are usually not centrally obese. So that's a second advantage. And here you see that, for example, that there is quite a strong correlation between waist and visceral fat measured by MRI or CT scan. So that's the reason. If there's anything that you do not understand, please interrupt. The other reason is this. If you look at BMI as a risk factor for myocardial infarction, and here's the risk of myocardial infarction, and here's BMI. Here's high BMI, here's low BMI. Here is red. You see that there is actually a graded risk. The higher your BMI, the higher your risk of myocardial infarction. But if you then adjust for blood pressure, diabetes, and dyslipidemia, most of that association is gone. In other words, BMI carries a risk, but that risk is explained by these other factors. Now, if you do the same for waist and myocardial infarction, then first you see that the association is steeper. There is a steeper association, probably because waist is a more specific measure of the dangerous fat than is BMI, as in the previous slide. And also you see, if you then adjust for other things, that more of that risk relation remains. In other words, part of the association between risk and myocardial infarction is explained by things like blood pressure, diabetes, dyslipidemia, but part of it is not. There is something else remaining, because if that were not the case, then this blue line should have been flat. Yeah? So that's the second reason why most people prefer waist. Practically, that poses a little bit of a problem, because in practice, the determination of BMI is very easy, and it is very reproducible, and you cannot make a mistake. But with waist, you can make many mistakes. It's not even so clear. There are different definitions of where you should actually put the taper. And you can easily imagine that if you measure somebody's waist now and in a year or so, and if your taper is not at exactly the same place, that may give differences in waist. So waist measurement is less reproducible in practice than is BMI. But from a pathophysiological point of view, waist is probably the better choice. So there are some people and some definitions that have called this the insulin resistance syndrome, as defined with regard to glucose metabolism. What is insulin resistance? What does it mean? Impaired glucose uptake as due to GLUT4 receptors as induced by insulin. There is insulin independent glucose uptake. Which is the most important organ that does not require insulin to use glucose?
Brain.
The heart.
Brain, yes. Brain. That's well, I guess that's the most important. Anyway, but so there are tissues that do not need insulin to take up glucose. They use GLUT1 transporters, by the way, but they don't need insulin. Erythrocytes, liver, brain. There are tissues that do need insulin, which is the most important, quantitatively the most important tissue. Muscle, yes, with adipose tissue coming second, but skeletal muscle. So insulin resistance means that this property of insulin is impaired. In other words, you need a higher amount of insulin, greater amount of insulin, to increase glucose uptake, which then leads to glycogen storage or glucose oxidation. And actually also, normal action of insulin is to decrease glucose production by the liver. So insulin has two ways of keeping your blood plasma glucose down: glucose uptake in skeletal muscle and decreased glucose production by the liver. Huh? So that's what in insulin resistance, these things are impaired. So you get something like this. If this is the plasma insulin level and this is glucose uptake, then this is the normal sigmoidal curve, and that is shifted to the right. And this is the curve that describes the decrease of glucose production with insulin. and that also gets shifted to the right. Importantly, as you can see here, if this is sort of the average condition of a person, then with these higher plasma insulin levels, glucose uptake is actually normal. And so is glucose production, only at the expense of a higher insulin level. Of course, that's why plasma glucose remains the same. If that were not the case, then plasma glucose would rise. Okay? So in an insulin-resistant person, plasma glucose is normal, but at the expense of high insulin levels. Whether that is bad is something we'll discuss. And this, in fact, is the reason why insulin resistance is falling out of favor as a concept that explains everything, because that was how it was introduced in 1988 by Gerald Reaven, famous paper in the journal Diabetes, where he said there is a syndrome, and let's call it the insulin resistance syndrome, because insulin resistance actually explains the syndrome. Well, that appears not to be so simple. Yes, many people with the syndrome are insulin resistant, but about a quarter is not. And vice versa, among people who are insulin resistant, about half have the syndrome and half do not. So when these data appeared, the concept of an insulin resistance syndrome simply explaining all the rest fell out of favor. And the term metabolic syndrome, which is more neutral, doesn't really say where the etiology is, gained favor. So if you follow that in time, you see that first people talked about insulin resistance syndrome, some people actually still do, but more and more that was replaced by the metabolic syndrome. In fact, there are some people who say that all this talk about the metabolic syndrome is actually a bit is something that is perhaps not so useful. So they have criticized the metabolic syndrome, and if you look at their criticisms, this is a list of their criticisms. And actually what they're saying is that prediction of type 2 diabetes or cardiovascular disease by the syndrome is no better than that by the sum of its parts. That's actually true. It is not better. There is no evidence of clinical utility. You can talk long about that, but as a clinician, I would by and large say that that criticism is correct. There is, if you compare talking about the syndrome to talking about the constituents, its parts, then as a clinician I do not find the metabolic syndrome particularly useful. The syndrome uses dichotomies. You're hypertensive or not. You have dyslipidemia or not. You have, well, those are. And you are centrally obese or not. And it sort of masks the fact that these risk relations with diabetes and cardiovascular disease are in fact of a continuous nature. It is not true that hypertensive people have all the risk and people below that cutoff have no risk at all. In fact, all these risk associations are more or less continuous and graded. If that is the case, then all these dichotomies are a bit misleading even. Theoretically, that's very correct. But in clinical practice, you actually need these dichotomies, because otherwise you have no tools of when to treat people and how to treat people. So pragmatically, theoretically, this is correct. Pragmatically, it's not, at least not for a clinician. This certainly is true. The metabolic syndrome is not a disease like hypertension. It's a risk factor for disease, but it's not disease itself. Nevertheless, there are important parties, important influences that would like it to be a disease. Because if somebody is a disease, you have a right to compensation, you can use drugs, and so on and so forth. So there are important sociological and financial consequences of disease labeling. How many of you thought that the metabolic syndrome was a disease before I said that it wasn't? None? Sure not. I bet that many of you thought that the metabolic syndrome was actually a disease. But it isn't. It's a risk factor. Then perhaps the most fundamental criticism of the syndrome is that the variables included are arbitrary and that there is no clear pathophysiological entity. If these were true, then we should stop talking about the syndrome. We could talk about obesity but not talk about the syndrome. So I'll suggest to you, and I'll show you in the rest of the lecture, that this is not true. The variables included are far from arbitrary, and the pathophysiological entity that is underlying all this is gradually becoming clearer. It's not perfectly clear, but it is becoming clear. So, this is it. This is where the metabolic syndrome results from. It results from dysfunction of adipose tissue. Dysfunction of adipose tissue happens mostly in obese people, but some non-obese people can have dysfunction of adipose tissue, logically, and in fact they do. But dysfunction of adipose tissue happens mostly in obese people, not in all obese people, in some obese individuals who are genetically prone and or exposed to specific environmental stimuli, physical activity, nutrition. They get this, which then leads, second step, to adverse changes in the release of mediators produced by adipose tissue, such as, but not limited to, inflammatory mediators. This is where inflammation comes in. Low-grade inflammation. This is not clinical inflammation, like if you have a fever, but this is low-grade inflammation. Other mediators released are non-esterified fatty acids, free fatty acids, that play an important role here. And this leads then to systemic low-grade inflammation. It by and large leads, not in all people, but in many people, it does lead to insulin resistance. It also leads to dysfunction of small blood vessels, and the importance of that I'll get back to. And the thing is, you don't need to have all of these, but you need to have some of these to make your next step. And that explains why some people have insulin resistance, but perhaps not the other things. And that insulin resistance in and of itself is not necessary to get the syndrome. And as I'll show you, this predisposes to type 2 diabetes, to high blood pressure, to hypertriglyceridemia. This is in fact the source of the dyslipidemia in the metabolic syndrome. Because if you go into lipid metabolism, then you will see that any situation in which triglycerides are produced more than normal and or used less than normal will predispose you to a lower HDL cholesterol. That's a passive consequence of the high triglycerides. It follows from lipid metabolism physiology. Also, the number of so-called small dense LDL particles increases. Those particles are considered to be especially dangerous with respect to atherosclerosis because they can get into the vessel wall more easily than the larger LDL particles. If you look at LDL particles, they are a family of particles, larger, smaller. The smaller are considered most dangerous, and in situations where triglycerides are high, LDL particles tend to shift, and I shall not go into the lipid metabolism of that. You could spend an hour explaining that, but the point here is this is the key thing in the syndrome. This is also measured, and it follows passively. We don't usually measure this, but it also follows passively from the high triglycerides. And all this then, type 2 diabetes, hypertension, hypertriglyceridemia, low HDL cholesterol, high LDL, small dense LDL, predisposes to both atherothrombotic and arteriosclerotic cardiovascular disease. So what it says here, apparently we have cardiovascular disease and we have two types. We have atherothrombotic cardiovascular disease and arteriosclerotic cardiovascular disease. What's the difference between these two?
Narrowing. In atherosclerotic, it's the narrowing of the lumen.
This is narrowing, that's
Sorry.
athero, and you get thrombosis at the end, right? If a plaque ruptures, you get a blood clot that obstructs the lumen. That's the thrombotic part, yes? So this is what we call atherosclerosis or atherothrombosis. What is this?
Just narrowing without the thrombosis.
No, it's not narrowing.
Stiffening of the
It's stiffening. It's stiffening, and this is a disease that starts with the vessel endothelium and the intima below the endothelium, where there is a plaque, and that plaque contains lipids. So it's a focal accumulation of lipids in the intima layer, and so on and so forth. This is a media disease. Here the media, which contains elastin fibers, which makes your blood vessels elastic, literally. These elastin fibers are damaged. They are damaged mostly by age and blood pressure, mostly blood pressure. Age cannot be changed, but blood pressure. These elastin fibers fracture and your arteries get stiff. And these stiff arteries are dangerous because they will transmit more of your blood pressure to target organs such as mainly the brain. So this disease is an important risk factor for stroke. And in fact also because blood pressure increases for left ventricular hypertrophy and the consequences of that, which are arrhythmia and sudden death. But there are clearly two mechanisms here. This is an intima disease. People with low LDL cholesterol do not have this. This is something that is related not so much to cholesterol but to blood pressure. Okay. And all this readily accounts for associations with of the metabolic syndrome with things like family or history of type 2 diabetes or cardiovascular disease, of many other variables. If you think about it, and if you draw arrows, you can draw arrows from each of these variables to the mechanisms that I've shown you on the other list. I shall not go into that in much detail, but this is the thinking. All these things predispose you to the metabolic syndrome because they influence the mechanisms that were on the previous slide. Most often they influence many of the mechanisms. Okay, again, stepwise. Let's talk a little bit about this dysfunction of adipose tissue. That simply means that by and large the view, and of course you all know that, but when I was at medical school I got taught that the adipose tissue is simply a sort of reserve organ where you store your unnecessary energy in the form of lipids or triglycerides, and otherwise it was a totally passive tissue. Of course it will come as no surprise to you that that view of things is from the past. We now know that adipose tissue produces an amazing amount of mediators that control things like its own volume, that control things like appetite, and they control things like metabolism. And this function simply means that somehow this normal list of mediators gets shifted to something that apparently goes wrong. So it's a very general term. But what is it then mainly what goes wrong? There is an increase of release of free fatty acids, and free fatty acids travel to the liver, where they induce insulin resistance. They travel to the pancreas, where they induce beta cell dysfunction, and they travel to muscle, where again they induce insulin resistance. So free fatty acids are important. Secondly, important, inflammatory mediators. Here, TNF-alpha, IL-6. Again, they go to the muscle, induce insulin resistance. They go to the liver, induce insulin resistance. And they go, well, actually, whether they have an effect on the pancreas is still unclear, but they also thought to affect beta cell dysfunction. They also, apart from not shown here, but here's the liver, but here is, let's say, blood vessels, they also affect the function of blood vessels. They increase atherothrombotic development. And finally, there is the mediator called adiponectin, and that's a special mediator because, funnily enough, adiponectin is something that is produced by adipose tissue, but when you increase your adipose tissue, the production actually decreases. It's a bit of a paradox. And why adiponectin secretion decreases when you have more adipose tissue is actually unclear. But adiponectin, in a way, is a good guy. Adiponectin normally increases insulin sensitivity in muscle and in liver. So decrease of adiponectin will impair insulin sensitivity in muscle and in the liver. So most things actually go up, most of the bad things, but there is one good guy that actually goes down. So these, I'm not suggesting, of course, that this explains all of these mediators, many other mediators, and many people have their own favorite mediator to discuss in this context, but there is widely held consensus that these mediators are important. But they are examples of what happens in adipose tissue. And the second thing I'll discuss then from here, adipose tissue dysfunction, and then there is this insulin resistance which follows from adipose tissue dysfunction. It is important to realize that insulin resistance with regard to glucose metabolism implies hyperinsulinemia. An insulin-resistant person with normal glucose levels has high insulin levels, as I shown you a couple of slides ago. If that is clear, then it has become apparent that insulin is not just a glucoregulatory hormone, it actually has many other functions. Can somebody? Other functions of insulin except glucose metabolism? Any idea?
Cell growth.
Cell growth, it has anabolic, yes, it has growth promoting effects, yes. What else? Some people think it's a risk factor for cancer because of that reason, yes. What else? Classic.
Fat uptake is also regulated.
It has effects on fat uptake, that's true, and on release of fatty acids. It is also the key anabolic hormone with regard to protein synthesis. If you have low insulin levels, protein synthesis is impaired. So it's not just glucose metabolism, it's also protein metabolism. So there are normal effects like decrease in adipose tissue lipolysis. Impairment leads to increased DFA. There is a normal effect which decreases hepatic secretion of very low density lipoproteins and apolipoprotein B. If that normal effect is impaired, we get an increase in triglycerides. The normal effect is to increase the activity of lipoprotein lipase, which is the endothelial enzyme that actually makes sure that you can take up your triglycerides into cells. If that is impaired, triglycerides will go up. So here you see why hyperinsulinemia, by and large, insulin resistance leads to high triglycerides. Insulin is also a vascular hormone. It normally dilates small and large arteries. If it cannot do that because you are resistant, blood pressure goes up. It impairs the synthesis or decreases the synthesis of procoagulant and pro-inflammatory proteins, such as fibrinogen, CRP. If it cannot do that properly, you will increase these processes, which increases your risk of cardiovascular disease. And there's another side of that coin. Because it so appears that some effects of insulin actually remain intact. Why that is, why you are resistant to this lot of effects and actually do not become resistant in other respects is unclear. But it is the case, and some of these normal effects at high insulin levels in insulin-resistant people can lead to excessive effects. So this is a further list of effects of insulin. Insulin increases sympathetic nervous system activity, again contributing to high blood pressure. It increases renal sodium retention. It's actually also a blood pressure regulating hormone. So high levels in insulin-resistant people, again, contribute to high blood pressure. So you see already that the high blood pressure in the metabolic syndrome is very multifactorial. It increases renal uric acid retention, which gives you hyperuricemia, which predisposes to gout. And that is why metabolic syndrome is quite strongly related to the incidence of gout. It increases ovarial androgen production. If this is excessive, it will increase among women the chances of getting this polycystic ovarian syndrome, with infertility as its and hyperandrogenism as the most common complaints here. It increases hepatic triglyceride synthesis. That's a normal action of insulin. But clearly, if that becomes excessive, you get steatosis. You get an increased amount of triglycerides in the liver, in liver cells. Non-alcoholic fatty liver disease, hepatic steatosis. That's why the syndrome is strongly associated with steatosis. And it increases the synthesis of antifibrinolytic proteins, the proteins that dissolve a blood clot. But antifibrinolytic proteins actually decrease the activity of those clot-dissolving proteins. So you get into this prothrombotic state. The third, I mentioned in this step, there was inflammation, there was insulin resistance, there's also dysfunction of small blood vessels. And that's the sort of final mechanism that I'll discuss. This is a cast of the microcirculation. Here are capillaries and small arterioles. And you need these capillaries to get glucose and insulin where you need to go, in muscle. So if you do not have these capillaries, like here, it is more difficult for glucose and insulin to go to muscle. Also, what insulin does is dilate these blood vessels. If they cannot dilate properly, or if you simply do not have them, glucose and insulin will not reach their target tissues, mainly skeletal muscle, and that also will contribute to this phenomenon of insulin resistance. The other thing is, this is where blood pressure dissipates. So you start with a blood pressure that is, let's say, 120/80, but in these small vessels, blood pressure goes down quickly. This is where total peripheral resistance is determined. And this is a parallel circuit, so if you have less of these blood vessels, total peripheral resistance will go up, and your blood pressure will go up. So things that impair microcirculatory function will do two things. It will make your blood pressure go up, and it will make your insulin resistance go up, or your insulin sensitivity go down. Here you see some of those associations illustrated. Here you see arteriolar function and here blood pressure. The better your arteriolar function, the lower your blood pressure. That's because of the peripheral resistance thing. And if you look at the number of capillaries, the more capillaries you have, the lower your blood pressure. That's again because peripheral resistance is less in people with many capillaries. Here one sees that here's insulin sensitivity measured in a so-called gold standard fashion. Doesn't really matter what it is, but this is the gold standard measurement of insulin sensitivity. And here you see that if your blood vessels are better, then your insulin sensitivity is higher. And that's because insulin and glucose are transported more easily to the target tissue. People who talk about the physiology of the microcirculation in skeletal muscle have found out that you have two types of capillary networks. So this is an incoming arteriole, this is the outgoing venule, and these are capillary networks. And the muscle is connected to all these networks. Except that you have so-called nutritive networks here that feed the muscle. This is where the muscle gets its nutrients from. And you have non-nutritive networks. They do not feed the muscle. They are there for thermoregulation. They are there to dissipate heat if you exercise. So what happens if you eat is that these vessels selectively open up so that glucose and insulin can get to the muscle. So insulin dilates these vessels at the cost of vessels here. You get a redistribution of blood flow and you get better transport of nutrients to the muscle. Here you see that is quite a spectacular effect. This is the rat hind limb. This is the basal state. This is what happens if the animal eats and insulin level goes up. I'll skip these. It simply illustrates the point that if your microcirculation is dysfunctional, you become insulin resistant. So the current thinking about this is that obesity leads to adipose tissue dysfunction. It actually also leads to increases in sympathetic nervous system activity, in the renin-angiotensin system activity, in the renal sodium retention. But obesity, in doing so, also leads to impairment of microvascular function, which is a sort of a second step. And these things directly and through this dysfunction of the microcirculation lead to insulin resistance and high blood pressure, linking these phenomena. Also, insulin resistance, of course, is a major risk factor for type 2 diabetes, which is down here, as it were. So microcirculatory dysfunction is thought to be a third, next to insulin resistance and to low-grade inflammation, to be a third intermediate step in linking adipose tissue dysfunction to things like type 2 diabetes and high blood pressure. And here you actually see that people who are obese, these are obese women, very obese actually, have worse microcirculatory function than lean women. And this is true both in the basal state, and insulin normally improves microcirculatory function, but that improvement is also gone. And here you see another experiment where insulin is transported through the skin, and you actually measure quite locally what happens. In lean people, you see vasodilation. In obese people, this vasodilation is totally gone. It cannot dilate. And this is not something that is just seen in very severe obesity. It is more or less a gradual phenomenon. Like all these variables are associated more or less linearly. Here we see that in people who are not really obese at all, this is sort of normal BMI. If your BMI, if you then measure visceral adipose tissue in people who are not particularly obese, then you see that the amount of visceral adipose tissue is related to microcirculatory function. The more visceral fat, the worse your microcirculatory function. And the same is true for the amount of trunk fat. So this is something that probably plays a role not just in very obese people, but also in people with normal sort of weight distribution. And how does insulin do all this? That has been elucidated. Insulin is, as I said, not just a hormone that works on glucose metabolism, it's also a hormone that quite specifically works on blood vessels. Insulin has a receptor on endothelial cells, and if insulin combines with the receptor, you get signal transduction, which in endothelial cells is the activation of PI3 kinase, same as in muscle cells. You then get phosphorylation of a protein called AKT, and in blood vessels or in endothelial cells you then get nitric oxide production and vasodilation. And interestingly enough, at the same time, signal transduction leads to activation of this kinase called extracellular regulated kinase, which leads to endothelin production, which leads to vasoconstriction. So it has entirely the opposite effect. Now in normal blood vessels, this, and in lean people, this is the more active pathway. Both are actually activated, but this one wins, as it were. And in obesity, this gets shifted to the left. This pathway is impaired, this pathway becomes overactive. And that's how, in obesity, people think that this microcirculatory problem occurs. Yeah?
Is this also the way that the different groups of vessels in muscle, as you told a few slides back, you have the vascular.
Yes. How does insulin produce this redistribution? It's in fact in some vessels it activates this pathway, in other vessels it activates that pathway, and the net effect is redistribution. And actually it's a very good question. Actually the thinking is, I mean, when people found this out, they thought, why does insulin have this strange property of inducing two opposing effects? Energetically it would be more efficient to just have one effect, more or less. Just take this pathway and access it and activate it more or less. Why are there two pathways and why are they simultaneously activated? And the answer appears to be that you need that for this efficient redistribution. Some arterioles need to be able to constrict in response to insulin. And how vessels know that they should constrict whereas others should dilate in response to the same signal is unclear. But yes, this is a strange, I mean, when people found it out, they were surprised, because this is not a normal sort of situation in physiology, that you activate two opposing pathways at the same time. And this is the thinking. That's far from certain, but that's the thinking. So, summarizing, I think there is reasonable insight. It's certainly not clear, but it's not definitive, but there is reasonable insight in the pathophysiology of the metabolic syndrome. And it starts with dysfunction of adipose tissue, leading to adverse changes in adipokine release. That in turn leads to this trio of things: systemic low-grade inflammation, insulin resistance, and microvascular dysfunction. By and large, they are connected. Some people have more of the one, some have more of the other. All this predisposes to type 2 diabetes, to high blood pressure, and hypertriglyceridemia, which is a sort of fourth step in this sequence. And then finally, at the end, all this predisposes to these cardiovascular disease, which is the more distant phenomenon. So I think if you have this sort of scheme in your head when thinking about the metabolic syndrome, you can more or less read most of the literature and understand about what part of this sequence, this part of the literature is actually talking. Okay, this was my final slide. Any questions? Is this more or less